over to plane B, the transthalamic plane. This is the measurement plane for the biparietal diameter. And then move down and tilt back a little bit, and you see that cerebellum cisterna magna. Another article, this is from Kearsmacher, just kind of color-coded. So if I show you this, just I know you're doing this every day, but if you're teaching anybody, thalami in this kind of blue area, the CSP highlighted here in red with the two leaflets present. Purple little golf balls are the cerebellum filled with the vermis in between as kind of a little heterogeneous echogenic piece of tissue that holds that cerebellar area together. We're going to talk a little bit about a measurement. It's one of the more common ones in the head. Obviously, we're taking biparietal diameter, the head circumference. We're measuring the cisterna magna. We're measuring the nuchal fold. We measure this lateral ventricle, and I'd like to spend a little bit of time on this because this is an important measurement that can generate a lot of controversy, unfortunately, if we don't do it correctly. And so there's several articles trying to set a standard on how we should measure these and whether or not you measure correctly. Hopefully this is the way you're doing it. You can see in this picture that we have the atria of the choroid plexus here. You can see the lateral ventricle present. And just like a nuchal translucency, the calipers should be applied inner to inner. We don't want to apply the calipers on the echogenic portion of the ventricle. It's the inner boundary of the lateral ventricle, not the outer boundary, and not diagonally, but really perpendicular to the fetal head. And then, so not only is this an inner to inner measurement, but also there's a location where we should be applying the calipers correctly. And whoever you're working with, whether it's your OB doc or an MFM doc or radiologist, I would encourage you to ask them. You say, hey, where am I actually supposed to put these calipers? Because I bet you they're unfamiliar with this word called internal parieto-occipital sulcus. If you see this little teeny indentation right here, it's a more subtle around 20 weeks, but definitely becomes more pronounced in the third trimester. This is what experts in the world would encourage us to be the exact location perpendicular to the lateral ventricle where we should be putting these calipers. And so in line with that parieto-occipital sulcus is where we should be doing this inner to inner lateral ventricle measurement. If I go back, you can actually see, here's the internal parietal sulcus. This measurement is actually not done correctly. It should be over here and a little bit further to the right of the screen in line with that anatomic landmark. So just a little bit of OCD-ness and attention to kind of an important measurement. The question is, why do I spend the time on this lateral ventricle? We'll talk about that next, because measuring the lateral ventricle can cause a lot of angst in the patient. This measurement should be under 10 millimeters. If it's not, basically you're telling them that maybe their baby's going to develop hydrocephalus. Then the MFM, has to go in the room and talk to them about how there may be brain damage as this progresses. The baby may not have as high of an IQ. And so this particular measurement we want done correctly. Should be under 10, just like the cisterna magna. And if you go through each of these planes, it's really unusual that there's going to be any further abnormality present in the brain. If you do see something unusual in the head, then we probably should not just be going transverse. We need to be going coronally and sagittally. And this advanced fetal intracranial ultrasound, they say, is use a fancy term called fetal neurosonogram. This is not something that necessarily needs to be done on every single patient, but if there is an abnormality in a transverse plane, then we should be moving on to these extra planes. There's 4 of them for the advanced coronal images. Transfrontal, just coming in. Point of this one is to see the interhemispheric fissure. Move back to the transcaudate plane to see the cavum. To look at the frontal horns, make sure there's no significant dilation. Move further back coronally, the transthalamic plane, and then further back the transcerebellar plane. You can see this plane's particularly useful to look at the vermis here. And then you have the cerebellum. Instead of looking like round golf balls, they look more kind of like maybe olives or grapes. But this is a very good image to look for any type of calcification in the ventricles and to make sure that the vermis and the cerebellum are accurately placed. Then there's two planes, mid-sagittal and parasagittal. Mid-sagittal is to make sure that this posterior fossa is actually down low in the posterior portion of the posterior fossa. You can see the third and fourth ventricle present. And then the parasagittal is more assessing, is there any kind of maybe calcification of that lateral ventricle, if you can get that very beautiful image like that. The head is attached to our spine, so head and spine tend to go together. When we're done looking at the head, we should move on to the fetal spine. In general, this is done in kind of two planes, a transverse plane and then a sagittal plane. I also think that a coronal plane is not a bad way to look at the spine as well. Transverse, you're running up and down from the cervical to the thoracic to the lumbar to the sacral vertebrae. That really should be a dynamic process. Yes, we're going to take representative pictures of the cervical vertebrae, thoracic vertebrae, lumbar vertebrae, and the sacral vertebrae, but we know that 4 pictures, there's many vertebrae, and 4 images is not going to do it. So maybe taking a cine sweep of these is something that we might recommend. Sagittally, we want to look and make sure that there's nice, smooth railroad tracks that are in parallel, that there's no evidence of any defect in the skin edge present. And maybe try to make sure that that conus medullaris is right around the L2, L3. That tends to tell you that that spine is normal. The shapes of each vertebrae, they kind of start rectangularly. For the cervical vertebrae, they look kind of like a little rectangle. They become kind of a triangular portion in the thoracic, a little bit flatter triangle in the lumbar, and then kind of a smush triangle in the sacral vertebrae. I'll have you notice in these pictures that each of these is right up against the uterus or the placenta. Ideally, when you're looking at the spine and transverse, you have some fluid in between you and the baby, so that there is not this compressed thing, because it's very easy to miss an ONTD that maybe is compressed. You're not going to see it if the baby is up against the wall. And really, really nice if that kid's anterior, not flipped upside down. A posterior spine, really tricky to look at. So ideally, the kid's up facing you and the spine's towards you. In the later part of pregnancy, we should see this conus medullaris, this kind of shadowed tip area, and the tail of this spinal cord, the cauda equina. That should end around L2, L3. That's a normal position. If you're seeing this kind of appearance way lower, there might be a tethered cord. There may be an abnormality of some of the bony development of that spine. So just a clue, we pull out maybe our EL18-4 linear transducer when we're trying to look at the spine. Can provide you some really nice images of the spine. You have to move slowly because of the frame rate, but it can reward you with some real high quality, accurate pictures. Okay, so I'm going to show you a few articles as we go through, and just kind of, I want to, these are here for your future homework. They're easily available on PubMed. And but these are just articles as I was combing through, lots and lots of different manuscripts and articles out there about each of the different segments of the fetus. I just wanted to share some of my favorites with you that you can review later. Imaging of the fetal nervous system, that article by Kiersmacher was a nice one. And then this article by Rittner, A Systematic Approach of Looking at the Fetal CNS System, was also a real nice review. Okay, so when you talk about abnormalities of any part of the fetus, you might use a textbook like this, Fetology by Dr. Bianchi, and you might open that book up to, the fetal head portion, and you're going to see, in the first chapter, there's going to be a lot of different anomalies out there. The anomalies we're going to cover, I'm going to try to cover the kind of common ones, the ones that, are useful for prognosis. And again, we're not going to cover every one of these, but there's a lot of things that we can see in the head that's abnormal. Ventriculomegaly, we're going to spend some time on. Spina bifida, really important. Dandy Walker malformations, destructive lesions, tumors in the brain, bleeding in the brain. There's a lot that can go on in the fetal brain. And so let's spend a little time on some of the common ones. Ventriculomegaly, definitely worth some time of our day. And again, I spent a bit of time for why that measurement's so important, to be in the proper position and have your calipers aligned properly. So ventriculomegaly is a dilation. It is not related to cerebrospinal fluid pressure. Hydrocephalus is pathologic dilation due to obstruction and increases in pressure. We don't know by just doing an ultrasound in the fetus that ventriculomegaly causes an increase in pressure. So I would recommend that you use the word ventriculomegaly when you describe this in an ultrasound report. Don't use the word hydrocephalus. It's not an accurate representation. Many times you'll see that used in fetal ultrasound reports, but really ventriculomegaly is the best way and the more accurate way to describe that finding. Ventriculomegaly is simply an enlargement of the cerebral ventricles. It's when that lateral ventricle is wider than 10 millimeters. So 10 to 12 millimeters mild, 12 to 15 moderate, over 15 severe. We love gradations. I'm going to have you try to remember that, 15 and greater, over 15, that's a serious problem for a fetus. And that's when definitely referral to an MFM specialist useful, and when maybe the prognosis for that fetus is going to be more guarded. Many times you're going to see ventriculomegaly. It may only be on one side. It's very difficult sometimes to see the near field ventricle. The far field ventricle on ultrasound is better visualized, just secondary to the nature of sound. But if you see it on one side, don't be surprised that you have bilateral ventriculomegaly. This is a really, really common abnormality. It's the most common abnormality of the CNS. It's considered a non-specific abnormality. It may indicate something else is wrong, but up to 1 in 50 babies may actually have this finding. When you see ventriculomegaly, when you come and you tell me there's 12 millimeters of lateral ventriculomegaly, I then go in and visit that patient. We talk, and I tell her, this is an abnormal feature and it has some prognostic implications. It's going to tell you that there's a higher chance of chromosome problem in the baby. If you have not done any genetic screening or genetic diagnosis, we might want to consider that. We're going to also then tell you that the severity of the finding, as that ventricle gets bigger, the outcome of the baby is worse. So mild ventriculomegaly, 10, 11, 12 millimeters, not a major big deal. 96% of the babies are normal. You get into the 12 to 15, 14% of those babies are going to have some neurologic abnormality. You get over 15 millimeters, over half of babies are going to have some neurodevelopmental outcome problem. So thus, the importance of the measurement being super accurate. It has a profound predictive ability on the outcome of the baby. What causes ventriculomegaly? Well, it can be totally random. Idiopathic, such a fancy word. It really means I don't know. It's one of my least favorite things, but ultimately a lot of causes in medicine are idiopathic. Chromosome problems, genetic abnormalities can yield this issue. Congenital infection, CMV, Zika, maybe COVID infection might damage a fetal brain. Bleeding in the brain can cause this. Injury due to lack of oxygen. Structural problems like blockage of the actual circulatory system in the brain, like aqueductal stenosis, can cause this. Let's talk about the outcomes based on severity. So, study by Gagliotti, 2005, 176 babies with ventriculomegaly in utero. A, mild, B, moderate, C, severe. Was the ventriculomegaly an isolated finding? Is it the only thing? So if it's mild, most of the time, over 60% of the time, you're going to have that be the only finding. As it becomes moderate, though, no, it gets more common. You're going to start to see other birth defects. Is the child actually alive 2 years after birth? 98% of the time, yes, if this is a mild 10, 11, 12 millimeter measurement. If it's severe, like 20 millimeters, sadly, only a third of those babies are actually alive at 2 years of age. The finding, the accuracy of the measurement, the size of the measurement predicts the outcome for the baby. Does the baby have a normal outcome like we hope and desire for our children? Does the baby have a normal IQ? If it's mild, almost always. If it's severe, 16, 17, 18 millimeters, 40, 50% of those babies are going to have some IQ deficit related to the ventriculomegaly. Patients then make decisions about what they want done. I would like an amnio because I want to rule out chromosome problems. We should be doing a microarray, which is a wide assessment of the karyotype and hundreds of deletion and duplication syndromes. When you see ventriculomegaly, you want to make sure there's no spina bifida present as well. So AFP, acetylcholinesterase evaluation on amniotic fluid, important. If there's other signs of viral infection, or she reports viral infection, we should do PCR for those viruses. Fetal MRI, should we do it, should we not? To determine, is there ventriculomegaly? No, you don't need the MRI. But to determine if there's something else incorrect in that little fetus baby's brain, the MRI is extraordinarily useful. And our practices, when we find ventriculomegaly, we strongly encourage patients to allow us to order and have them undergo a fetal MRI, because it actually finds a lot of things we can't see on an ultrasound. And the likelihood of an MRI actually finding other anomalies is upward of 50% of the time. Here's a study of fetal MRI done in the setting of when we find what we think is isolated ventriculomegaly. 150 babies, they see a ventricle over 10 millimeters. Every one of them got an MRI. And amazingly, we saw like 1 in 5 extra things. 20% of babies had something extra when we thought it was just ventriculomegaly. And actually, agenesis of the corpus callosum was one of the most common abnormalities. So, real big benefit by doing fetal MRI. If you see ventriculomegaly and you're working in an ER, you're working, in a general OB office, this is why it's important for recommend MFM referral. You could put in there, consider fetal MRI due to the high probability of finding other abnormalities. Your recommendations, I would put that in the report, tell your radiologist, encourage them to do extra work to take care of that patient. This is just that study showing, as the ventricle gets bigger, the likelihood of finding more abnormalities is higher. So, a relative risk of us finding something else in a baby's brain, mild, we're finding 17%, but actually if it's severe, like 17, 18, 19 millimeters, there's a 10 times more likely chance. So we're talking, almost all those babies are going to have some other finding on their MRI. Here's just an example from an article from Griffiths. You can maybe say, I know I don't have the ultrasound, but here this ventricle looks normal. This ventricle is definitely dilated. But if you don't do the MRI, we probably just call this massive ventriculomegaly. But the MRI gives you this fine little, kind of image of a round structure here, which actually is an interhemispheric cyst, requires surgical intervention, definitely can grow, definitely can cause damage to this side of the cerebral hemisphere. And so greater accuracy and additional information for the patient to guide treatment, counseling, and care of that fetus and then that newborn. We would have seen just ventriculomegaly, but the fetal MRI are real helpful. So takeaway, in utero magnetic resonance imaging shows a really high detection rate of additional brain pathology when its supplements are antenatal, prenatal ultrasounds. And so it is definitely our practice, I think, in the United States, very commonly in New Mexico, Perinatal Associates in New Mexico. Every single abnormality that we see of ventriculomegaly, we do recommend fetal MRI. Sometimes the insurance companies do not love to pay for that. We fight for that based on the articles that we showed you, that it definitely does guide and help the patient in further prognosis. We often don't find in etiology. There are common genetic circumstances when you do that amnio. Maybe that we identify Down syndrome, trisomy 21. CMV is a common virus, so don't be surprised that you might see that on an amnio for PCR. We always want to counsel the patient depending on the severity, all of the other findings, what the genetics are. In pregnancy in the United States, it is a legally available option. It is unethical to not talk to patients about all their options. You can continue a pregnancy and you can choose not to continue a pregnancy. Termination of pregnancy is an option. That is something that we do talk to patients about on a regular basis. It is a personal decision and we respect those decisions that those patients make. And ventriculomegaly brain abnormalities are one where that may be something that is chosen and elected by the patient. You guys often are the ones, making these diagnoses. You're the first person to tell that patient there's something wrong with their baby's brain. I think it's really important. We try to let our sonographers share a bit of information with patients. And, regardless of whether or not you talk to the patient much or not, they actually can read your face really well. And so I think, again, why these types of courses are really important is that you can let the patient, understand what the finding is and maybe how significant the finding is and the importance of their follow-up with that MFM doctor and the subspecialist. You may not be an absolute expert in, everything, and we understand that, and I think patients understand that, but a little information goes a long way, and it's just, I think, a kind circumstance. So as a sonographer, I think it's super important to understand some of the severities. You can say, yeah, this is probably going to be okay, or, this is actually really significant. We do need to see that specialist. Here's a meta-analysis of 20 different studies. Almost 700 cases of isolated ventriculomegaly, mild or moderate, so 10 to 15 millimeters. And the takeaway I'd like you to have from this is that under 15 and over 15, you have an understanding of what that means for ventriculomegaly. So under 15 millimeters, 95% of babies have a normal karyotype. So of those amnios, 1 in 20 is going to be abnormal. Only 8% of those babies have any delay in their learning, so 92% of them are normal. And we do find some additional findings, but it's still pretty rare. 93% of babies have no other finding other than just mild or moderate ventriculomegaly. So takeaway, mild, moderate ventriculomegaly under 15 millimeters. Yes, there is a chance the baby may have some medical complications, but at 95% of the time, the baby is going to do perfectly well. In contrast to that, severe ventriculomegaly over 15 millimeters, this is problematic. And the outcomes are definitely what we would say are guarded. So stillbirth in these fetuses occurs not uncommonly, and actually neonatal death does not occur uncommonly. Over 10% of these babies will die in pregnancy or shortly after birth. How well do they do neurodevelopmentally? Unfortunately, almost half, 40% of babies with severe ventriculomegaly will have severe neurodevelopmental delay. So a profound IQ deficit, significant learning disability, necessity of occupational therapy, physical therapy, speech therapy, potentially lifelong, and significant educational assistance throughout their life is going to be almost half of these children. And moderate impairment, 20%, so 20 plus 40, 60% of kids. This is not a circumstance that has a rosy prognosis. Unfortunately, it is a significantly guarded prognosis based on that accurate, properly placed ventricle measurement that you made. And 10% of the time, we find things after the baby's born, other diagnoses present. So under 15, very probable you have a good outcome for that child. Over 15, guarded prognosis, and actually a poor prognosis for the child. How do we follow the patient once we make this diagnosis in utero? We've done all this counseling, we've offered amnio. They definitely should get another ultrasound. Third trimester, 28 to 34 weeks, recheck all of the anatomy, remeasure the ventricle. Interestingly, almost 20% of these are going to get worse, and the counseling is going to change. So as you see progressive ventriculomegaly, those outcomes vary for the baby based on the size of that ventricle. And interestingly, we detect other abnormalities in about 10% of these babies. Should we do antenatal testing, BPP testing on these patients? There's not specific guidelines on this, but interestingly, when we put all babies with major birth defects into a study, they definitely all have a higher stillbirth rate. So experts, MFMs, we definitely monitor these babies, usually at least on a weekly basis, to make sure things look and that the baby's acting normally. How should we time the delivery? We usually allow them to deliver at term. There's no reason to deliver them early simply based on the ventriculomegaly unless maybe there's massive enlargement. Almost all of these babies in regards to the route of delivery can deliver vaginally, but we want to make sure when we see significant ventriculomegaly in a fetus, sometimes that actually can cause head circumference enlargement. And a measurement in every sonographer's head that should be burned into your memory is 40 centimeters for a head circumference. If the HC is 40 and above, the head is not going to fit through the vagina and the pelvic canal. And so those patients really should be delivered by cesarean section to avoid trauma to the fetus, the baby, as well trauma to the mother. They should deliver these children in a tertiary high-level facility to allow for a head ultrasound, head MRI, NICU care, peds neurosurgical care, so that these kids, many of which are going to need a VP shunt. They also should get genetic counseling. Anytime you make a diagnosis in a baby, they're going to want to know, is this going to happen again? So we have these patients all see genetic counseling. If it's a male, this may be something called X-linked hydrocephalus, of which there's a 50-50 chance in every subsequent pregnancy when it is a boy. It may be just isolated, and that doesn't recur very frequently. So if it's isolated ventriculomegaly, we should give reassurance to the patient they're not going to likely experience this again. And as you'll see as a theme as we go further along in the day, these patients deserve an MFM consultation and a detailed anatomic ultrasound in any subsequent pregnancy. Great articles if you want additional homework. Mild Fetal Ventriculomegaly by SMFM's little series here by Dr. Fox. Counseling in Isolated Mild Fetal Ventriculomegaly by Melchior. There's 2 articles to that one, mild and severe, just how we should talk to patients about these findings. So just some additional reading if you want. All right, so we're talking, about the head, and ventriculomegaly might actually give away another abnormality. And that other abnormality is that very, very difficult one that we talk about, which is an open neural tube defect, or what we know as spina bifida. So let's talk a little bit about spina bifida, if you don't mind. Spina bifida is an incomplete closure of the bony elements of the spine. 80% of these are open. We have 2 terms that you should be aware of. Meningocele, that has no neural tissue, no spinal cord contents. And then you have myelomeningocele, or an MMC for short. And that definitely has spinal cord present within it. Sometimes these defects are hard to see. They can be closed. They may be an internal lipoma or meningocele, and maybe you need a physical exam to actually see a dimpling or hyperpigmentation or a little skin tuft, a little hair on a baby's back, so you could do an x-ray and make that closed spina bifida diagnosis. But 80% of these are open, and they tend to be a little more obvious. We travel all over the world. We take care of patients that are traveling all over the globe. I think it's really just interesting to see there is a greater frequency of spina bifida depending on what country you live in. In the US, our rate is pretty low. Europe, a little higher. Asia, much higher. And Eastern Mediterranean, like Turkey, quite significantly higher. Why do I show you this? Really just to say, we take care of patients from all over the world. Maybe you're taking care of a patient from Ankara in Turkey. That baby has a higher chance of spina bifida simply by the nature of where that patient's from, primarily due to the diet of patients and how much folic acid they're taking. Most isolated NTDs or neural tube defects are related to folate deficiency. The mother either doesn't get enough orally, maybe she's had a gastric bypass type of surgery that she doesn't absorb it correctly. Maybe she's taking a seizure medication like valproic acid, or she's taking methotrexate for an immunologic disease. These all cause trouble with metabolizing folic acid. You don't get enough in the first trimester, 0 to 11 weeks, and then you get a baby with spina bifida. Other reasons I love giving talks is that I actually didn't know this, but if you have a fever really early in your pregnancy, right at around conception time, chance of spina bifida is 3 times higher. So being aware of fever, controlling fever, actually may have an impact on spina bifida rates in your daughter, your loved one, your sister. If we're overweight, that has an increased rate of spina bifida, so a need to be healthy, lose weight prior to conception. And we want to control pregestational diabetes because it also has a heightened chance of increasing that rate of open neural tube defect. We know initially from women that had a baby with spina bifida that if we give them a very large amount of folic acid, huge reduction in spina bifida rate. And if we give them less, they have still a huge reduction. So folic acid in any human that's had a baby with spina bifida, or the mother has spina bifida, or the sibling or partner has spina bifida, higher doses of folic acid are incredibly important. What if we just treat like everyone with folic acid? In the 90s, we really didn't know the answer to this. So we gave a lot of women 800 micrograms of folic acid. The women that got folic acid, none of them had spina bifida. The ones that got placebo, there was a 6 number of spina bifida. So folic acid is extremely helpful to prevent spina bifida. We supplement a lot of our grains with folic acid. We should take folic acid in a prenatal vitamin, and any loved one of yours, female that is of childbearing age, she really needs to be taking a multivitamin with folic acid from age 10 to 50 when we go into menopause in order to prevent spina bifida. Simple prevention by taking a vitamin every day that has folic acid. And you can tell them that they're going to reduce their risk of having a baby with spina bifida by 70%, which is a profound reduction with something really, really simple. When should they be taking all of this? So you're considering getting pregnant. Your sister, your daughter wants to have her first child. She needs to be taking a prenatal vitamin ideally 3 months before conception. Or better, take it every single day of your entire life, and we'll get in a habit and we won't ever have this difficulty with spina bifida if we do. Unfortunately, though, lots of people don't take a vitamin. And so we need these kind of guidelines. Tell your friends, your loved ones out there, we definitely need to take a vitamin for at least 3 months prior to conception, and then for sure in the first 0 to 12 weeks of their pregnancy. This is not only helpful to prevent spina bifida, helps prevent cleft lip, also helps prevent chromosome abnormalities. Our chromosomes run along a little train track called a spindle. And if we have patients that take vitamins more frequently, they actually also have less chromosomal abnormalities. And then another takeaway that I would share with you is that if you do have a fever in a pregnancy in that first trimester, don't be afraid to take acetaminophen. Acetaminophen is an antipyretic, Tylenol. It's very easy, readily available everywhere in the world. It is safe in pregnancy, and it is profoundly beneficial to lower the rate of spina bifida in case maybe you have strep throat or a cold or COVID or a UTI that causes a fever, any infection-related fever. If that woman takes acetaminophen, she can reduce her chances in the first trimester of having a baby with spina bifida by 44%. Huge benefit. Didn't actually know this actually existed in the literature, but a really important study. Please use acetaminophen if you have a fever when you're pregnant in the first trimester. Why do we want to spend some time and talk about open neural tube defects? Well, you know, this is a real significant problem. It has a massive burden on the child, on the family. It's typically not a lethal abnormality, so the birth defect is going to yield complications for that child for long periods of time that are both physical and neurologic. The spina bifida can cause pressure changes, obstruction that causes hydrocephalus, and actually may damage the brain, cause cognitive impairment. We want to screen for this. We want to do this by ultrasound. We want to do this by blood testing. We used to do this just by blood testing, but we really have found that this is better detected by ultrasound. Spina bifida blood testing should not be the only way to screen for open neural tube defects. Routine second trimester ultrasound, I know we do it everywhere in the United States, but it's a direly important way of detecting spina bifida. In the past, we didn't do this, and now that we do, we lowered the rate of detection of missing spina bifida dramatically, because in the old days, we actually only used a blood test. We can see this abnormality often in the first trimester, especially if you're looking carefully with a vaginal ultrasound. But our detection rate is as high as 95% if you do a 22-week ultrasound. And this is evidenced by this article by Martin Cameron and Paul Moran. Again, how should we be looking at spine? Transverse, sagittal, coronal. Look at the vertebral bodies. Look at the skin edge, coronally look at any changes in actually the bony structure of the vertebrae. Look for that conus medullaris. You know, at early pregnancy, it's down low. By, you know, mid trimester, third trimester, it should be up towards L2, L3. You see this little shadowed tip area and this little echogenic area. That's the end of the spinal cord. The conus should be about L2. It should progressively get higher as we end the pregnancy. If it's not, then there's likely something wrong with that spine. Just an extra clue. This is obvious. Spina bifida, what we call a myelomeningocele. Why? Because you can see the cauda equina, the spinal cord, actually in the defect. We don't want to just say, hey, there's a sacral spina bifida. We really want to look at and count the vertebrae and say, okay, where's the uppermost lesion? Well, this is probably like a L4, L5 because there seems to be a bony abnormality here. Maybe, you know, provide a little bit more information in our reports because the upper level of the lesion ends up being the one that's the predictive one. This is a good image because you see the fluid in between the fetal skin and the uterus. This is an acceptable one. This is not great because you see the uterus and the skin edge. Don't push so hard. Let a little pressure off on the transducer. See if you can get some space, some fluid in between the baby and that uterus. Remember to look at the rest of the baby. You know, ventriculomegaly is a good sign for this. Club feet, also a real important sign because the baby's not moving the legs as well, and you get a valgus kind of interning a rotation of the foot, and this is something that we might see when we have a baby with spina bifida as well. You can see some bleeding in the brain, some kind of echogenicity, nodularity in the choroid plexus. We should always try to be documented spontaneous movement. Is the baby moving upper and lower extremities? Document that in your report. Look for spina bifida if you see club feet. Look for spina bifida if you see ventriculomegaly. What are the tip-offs we're going to see when you see a baby with open neural tube defect? The head often is the source of other abnormalities. We're going to see significant ventriculomegaly. You're going to see a effect of concavity where we don't have positive pressure pushing the brain forward. You have suction backwards. It sucks the skull in, making a lemon shape, and it sucks the posterior fossa back, making a banana shape. Why? Because of a loss of positive pressure, the opening in that spine, the cerebrospinal fluid outside in that MMC or meningocele causes the brain to look abnormal. That lemon sign, classic on every examination, the shape of the skull, we pick that up right off the bat when we're looking at the head. This can be seen, these effects can be seen sometimes very early, almost always seen at that mid-trimester exam. Don't be deceived, though, if the lemon sign is the only subtle marker. 1% of normal babies do have kind of a subtle lemon sign, so it is not 100% sensitive in predicting spina bifida, but it is a pretty good one. Lateral ventriculomegaly, as I said, over 10 millimeters. Almost all babies, upwards of 90% of babies with the spina bifida are going to have ventriculomegaly. So again, the head predicts other abnormalities. Any head abnormality, start looking at the spine. You're going to see ventriculomegaly in almost all babies with spina bifida. 90% of them have ventriculomegaly after 24 weeks. And so this is a common feature. The banana sign, this kind of, compression and hindbrain herniation is a common one as well. It's a requirement, actually, if in utero surgery for spina bifida repair is ever to be considered. I will tell you, though, that if the cerebellum, the vermis, the cisterna magna, the lateral ventricles, that posterior fossa, if it looks normal, everything measures appropriately and it's anatomically normal, it's highly unlikely there's anything else wrong in the brain, and there's highly unlikely there's spina bifida. Babies with spina bifida, on occasion, 1 in 5 have some other abnormalities. Clefting, cardiovascular abnormalities are common. So always send these patients from a level 2 to a level 3 ultrasound. They need MFM evaluation. Always encourage patients to consider doing a microarray diagnostic testing. If we see spina bifida with another heart defect, 1 in 4 chance of having a chromosome problem. So cleft lip, spina bifida, amnio recommended. Cleft lip or spina bifida and a heart defect, definitely recommend amnio. If spina bifida is the only finding, it actually is exceedingly uncommon. 98% of patients don't have any evidence of a chromosome abnormality. If patients qualify and want in utero surgery, they must have an amnio as well to know that we're doing surgery on a genetically normal fetus. Every single baby, like with lateral ventriculomegaly, if there's spina bifida, we definitely recommend MRI because it changes our management. It tells us the lesion level maybe more accurately. It's not uncommon that clinical management is changed when we do fetal MRI. So if there's a head abnormality, MRI. If there's a spine abnormality, please get a fetal MRI. We go in and talk to these patients. We offer them genetic testing. We talk about ongoing management of the pregnancy. What's the prognosis? The prognosis, like lateral ventriculomegaly, is going to be based on the level of the lesion. The most important predictor of neurologic function is the upper level of the myelameningocele lesion. The first question the patient's going to ask you when you tell them that their baby has spina bifida is my baby going to be walking? Is my baby going to be paralyzed? This is a super important curve that I'd ask you to pay attention to, because often patients with spina bifida are not told information on an accurate basis. When the defect is very low in the sacral spine, yes, there's spina bifida, but almost all of those children will be ambulatory. So nearly 100% of babies with a sacral lesion will be walking. If it's at L5, 91% of those babies are walking. However, as we get to L4, 57%. If the lesion is at L2, L3, unfortunately, that's where we see profound effect on the baby's ambulation. And so paralysis, wheelchair bound, L2, L3 is the number that you want to burn in your mind. Below that, encouragement of normalcy is a good thing for the patient's well-being. Is the baby going to grow up and go to college and high school? Most of these babies actually do have normal intelligence, but these babies require a lot of care. Their ventriculomegaly and hydrocephalus often require repetitive VP shunts. Almost all of them, if it's a lumbar lesion, less common with sacral lesions. And bowel and bladder function is also another really common question. Almost all of these babies, actually, almost 80, 90% of them are going to have normal continence of urine and bowel. Why spend time on that little part about ambulation and effect? I mean, you're just the sonographer. I'm just the doctor. I mean, we're like, I'm not a pediatric neurosurgeon. They can tell the patient about what's going on. The reason I think this is important is, as I told you before, I'm the first person that tells patients what's wrong with their baby. It's profoundly impactful to that patient when you walk in there and say your baby has got spina bifida. And it's important that we, as in this editorials article, that we tell the truth about spina bifida. Because at the end of the day, although a very scary diagnosis and one that's going to require surgery, the great majority of these children grow up to young adults with normal intelligence that are walking and have continence of both their bladder and bowel. And so we know from research and studies and conversations with women that when they get an ultrasound diagnosis of open neural tube defect, it was a momentous event for them that evokes a devastating amount of experiences. We need to share the information in a compassionate way, an honest way, but also in an accurate way. If you don't know what the outcome is going to be like, then tell them they need to see a subspecialist, try to give them confidence. And after listening today, when you see a sacral spina bifida, you can tell the patient, based on research, based on a lecture I recently heard, in general, those babies do really well. Yes, your baby's going to need surgery. Yes, the baby may need a ventricular peritoneal shunt, but in general, the outcome is good. So we don't want to steal every hope away from that pregnant person. We want to give them an accurate diagnosis so they don't have this ultrasound diagnosis with a ton of devastation. There is ex utero and in utero repair of spina bifida. After the baby's born, it definitely requires repair. Sometimes babies qualify for surgery in utero, and this is a very interesting way of fixing these in a few specialized centers in the United States. We have to have hindbrain herniation and ventriculomegaly to qualify. They must have an amniocentesis, and in general, the patient's weight needs to be with a BMI lower than 30 to 35 so they can accommodate actually entering the uterus and doing this safely. When the repair of spina bifida is actually done in utero, they see a reduction, 30% reduction in that repetitive shunting, which is an important outcome because there's always a chance that that can cause infection and harm to the baby. And then, interestingly, there is a benefit to motor function when repaired in utero. That was a secondary analysis in this New England Journal of Medicine article. So babies actually do better. They have less shunts and they have better motor function if repaired in utero, if they meet the criteria. If you have spina bifida and the brain looks normal, there's no ventriculomegaly, there's no banana sign, they don't meet criteria for surgery. How do I follow this patient once we've made that diagnosis? So they should be followed typically on a monthly basis. Make sure that the head size is not changing, that the ventriculomegaly is not developing or worsening. And at the end, yes, we do antenatal testing on these patients typically on a weekly basis. When you deliver these patients, we want to get them as far along as we possibly can, term 37, 38, 39 weeks. The delivery should always be done with non-latex gloves. If the baby is exposed to latex, that spina bifida has any latex exposure, those patients can develop, the kid actually can develop crazy life-threatening latex allergies. So that this is a little thing to remember if you ever are delivering a baby with spina bifida. And interestingly, many of these babies are going to be breached because they don't kick and move their lower extremities, and so they tend to not turn. And so planned C-section for those babies is pretty common. But if the baby is head down or vertex, having a baby vaginally with spina bifida seems to be the exact same outcome as having a cesarean section. So Cesarean section is a big surgery for a mother. And if we can safely have a vaginal delivery, these kids tend to do perfectly well with a vaginal delivery. Every time a baby's born with spina bifida, that mother, that father needs genetic counseling. The parents should get genetic counseling done. Risk of recurrence is low if you have one child, maybe as high as 4%. But if there's 2 kids with spina bifida, we tend to see that happen frequently, as high as 1 in 10. Supplementation with a significantly higher amount of folic acid. If you ever have a child with spina bifida, or you have a sibling, or the parent has spina bifida, please make sure that that patient is taking 4 milligrams preconceptionally and in the first trimester of her pregnancy. Couple good articles: American College of Obstetricians and Gynecologists Practice Bulletin on neural tube defects from 2017. Beverly Coleman, The Diagnostic Features of Spina Bifida, the Role of Ultrasound, a really nice article. And if you're interested in the actual surgical repair of spina bifida, this article here by Dr. Adzik tells you all about those pre and post outcomes when we actually repair spina bifida in utero. All right, so we're cruising through the head. Hopefully you guys have a little coffee on this nice early morning. Let's do one other fetal head abnormality. I like to talk about Dandy-Walker malformation. This one's important. The importance of this one is related again to like the accuracy of the diagnosis, what's the terms we're using, and hopefully some of these, I think this is a pretty uncommon one, but it's really important that we use proper terminology because it predicts the prognosis. So Dandy-Walker malformation is a combination abnormality. You see hypoplasia of the vermis or complete absence of the vermis. You see a dilation of the fourth ventricle, and it changes the size and shape of that posterior fossa. Originally described many years ago, 1914, by Dandy and Blackfan. And since its early descriptions, as ultrasound has become mainstay and imaging has gotten better and our understanding has improved of this, you know, we often come up with different terms. There's different anatomy that can lead to different abnormalities, and they all have different names. And so we want to pay attention to the names and the classic diagnosis for each of these. There's a lot of different terms: Dandy-Walker malformation, Dandy-Walker variant, agenesis of the vermis, megacisterna magna, Blake's pouch cyst. I mean, what are all these things and what do they mean? Let's talk a little bit about it. So this is a complex anomaly of the cerebellar vermis. Usually the fourth ventricle closes, but when this fails to close, you will see a kind of persistence and growing of Blake's pouch cyst that usually might start to appear around the beginning of the second trimester. It is rare. 1 in 5,000 births has a Dandy-Walker malformation. You're not going to see this every single day. And it's important to really use strict criteria. And this is a picture I'd ask you to try to kind of burn in your head. There's a complex of different posterior fossa abnormalities. And, investigators have said, well, maybe we should just lump them all together, call it a complex. But the problem is like, as you'll see, some of these posterior fossa abnormalities, like, they don't have nearly as bad an outcome as maybe the classic Dandy-Walker malformation. So there is really an importance to not lump these into one group because the prognosis varies really significantly, and we want the patient to have accurate information. We also want to understand our capabilities as humans with ultrasound machines to predict Dandy-Walker malformations. So when we think there's a problem on prenatal ultrasound and then do an autopsy, we actually are wrong 40% of the time, and maybe we're kind of uncertain 20% of the time. So We thought something was wrong with the posterior brain on an ultrasound. The patient may be elected to terminate her pregnancy on the basis of that information. And we were totally incorrect in 40% of the patients, and we are probably incorrect in 20%. So interestingly, Dandy Walker malformation was not fully confirmed on almost 60% of autopsies. So the takeaway on this is be very careful with this particular diagnosis. It conveys a very bad outcome for the patient's baby, and they may act on that diagnosis. So we want to be confident that this is a real Dandy Walker malformation, and clearly we're not great at making this diagnosis on ultrasound. Our correlation of ultrasound of Dandy Walker malformation and actual real neuropathology findings is really poor. For that reason, we want to reserve the specific diagnosis of Dandy Walker malformation to when each and all of the classic findings are present. What are the classic findings? There should be dilation of the cisterna magna. The vermis should be absent, and there should be a trapezoid triangular interhemispheric gap. This doesn't look normal. Where's the vermis? It should be a heterogeneous little echogenic structure. There is no vermis. Okay, aplasia of the vermis. If I measure the cisterna magna, it's huge. Okay, enlargement of the cisterna magna. And there is a trapezoid or triangular cystic mass in the posterior fossa. This looks to be a classic Dandy Walker malformation. We don't want to call this abnormality early. The vermis, interestingly, is not fully developed. It looks open very commonly at 14, 15 weeks. 56% of the time when you look at a first trimester ultrasound, and this is important because we're doing a lot more first trimester detailed anatomic ultrasounds, don't be confused. The cerebellum may look like this at 12, 13, 14 weeks. Don't overcall Dandy Walker malformation in the first trimester. Wait till at least 18 weeks. After 18 weeks, if you see this, 100% that's abnormal. We want to look at all the planes, okay? We want to use that transcerebellar plane. We want to use that transcerebellar coronal plane to look, is there a vermis or is there not, okay? Make sure you get some good suspicions using multiple different planes. Look mid-sagittally. Does the cerebellum look nice and situated in the posterior fossa? Or is it tented upward and superiorly with a big gap in the lower posterior fossa? That mid-sagittal plane, the transcerebellar coronal plane, and that transcerebellar transverse plane are the most important imaging planes for this diagnosis. Again, classic diagnosis transverse, classic diagnosis mid-sagittal. You see a big trapezoid cyst, splaying of the cerebellar hemispheres, and the vermis is essentially completely gone. Just some cartoon pictures of that from an article by Robinson and then another one by Chabot. And then on MRI, again, any abnormality in the brain, we lean very commonly on fetal MRI. You can see, again, a very nice tented tentorium and this big dilated Blake's pouch cyst. What's the spectrum of Dandy Walker malformation? You know, what are some other things that might get us confused that we see actually in the posterior fossa? Well, interestingly, there's something called just vermian hypoplasia. So maybe that vermis just develops incorrectly, but there's not a big cyst in the posterior fossa. Maybe the cerebellum and the vermis look completely normal, but there is a big enlargement of the cisterna magna called megasisterna magna. And maybe we just see like a central little posterior cyst in the posterior fossa, and that's a Blake's pouch cyst. Vermian hypoplasia is the term I'd suggest we all use. Looks, you know, kind of like a little keyhole abnormality. This is not that classic triangular abnormality. You see a little indentation of tissue here. The vermis is absent, still present, this is not a great ultrasound picture, but the point of this mid-sagittal is this part is not tented up, okay? So the cerebellum and the posterior fossa are nice and low in the head. They're not up in the tentorium due to that cyst, Blake's pouch cyst. This is a real common overcalled diagnosis. So look for a little tissue and absence in the center of the two cerebellum golf ball kind of structures. That's going to be that Vermean hypoplasia. Megacisterna magna. Well, here, let's see. Cerebellum on both sides looks good. We see the vermis looks good. If I measure this, though, there's just this weird ovoid enlargement of the cisterna magna. That is megacisterna magna. You see the cerebellum placed low in the fetal head on that mid-sagittal plane. It's not elevated. That's just going to be an abnormality of the cisterna magna. And then Blake's pouch cyst, again, mid-sagittal, the posterior fossa is low in the fetus's head, not tented upwards. So that is the trick of that mid-sagittal plane. If you see a tented and elevated tentorium of the posterior fossa, think Dandy-Walker malformation. If it's low, think about Blake's pouch cyst, think about megacisterna magna, think about Vermean hypoplasia. Yes, there's a little cyst here. The cerebellum is splayed a little bit, but it does not look triangular. It's not a big trapezoid gap. So that's not going to be Dandy-Walker malformation. This is a Blake's pouch cyst. Why do I pound this into your head today? Well, we start with routine ultrasound exams, and we have all these different differential diagnoses. How do we, go about making this diagnosis? Sorry, these are busy slides. We need to do a detailed ultrasound on these because, if we think it is really that classic Dandy-Walker, there's going to be a lot of other abnormalities present. Heart defects, cleft lip, cleft palate, problems in the brain, high rate of chromosome abnormalities if it's a true classic Dandy-Walker. Please order a fetal MRI on these patients because that commonly also helps make the diagnosis, and it can exclude the diagnosis as well. There is no way to fix this in utero, and it has a pretty profound chromosome abnormality rate and IQ rate. Ventriculomegaly, extremely common in Dandy-Walker malformations, and we've told you about the outcomes associated with severe ventriculomegaly. The great majority of these babies require VP shunts. 60% of babies with Dandy-Walker malformation will go on to have neurodevelopmental delay. Dandy-Walker malformation, poor prognosis. What about Vermean hypoplasia? Just that little absence of the vermis. Well, interestingly, though, these babies actually don't develop ventriculomegaly. They don't require shunts, and they don't really have any IQ deficit. So having a little bit of absence of the vermis, according to D'Antonio, not harmful to their baby. So the prognosis predicted by the lesion, super important that we maintain accurate diagnoses for our patients. Maybe there's just a megacisterna magna. Hardly ever get ventriculomegaly, never require a shunt. Maybe 1 in 10, 1 in 8 develop some IQ deficit. So a little guarded, but still very, very favorable diagnosis with a megacisterna magna. Blake's pouch cyst, they can develop ventriculomegaly, so they need some serial ultrasound. They rarely need a shunt, and they don't have IQ deficits. Takeaway on all of this, children with prenatal diagnosis of Dandy-Walker malformation, the classic one, splayed cerebellum, trapezoid abnormality, a big trapezoid cyst in the posterior fossa, tented, elevated posterior fossa on the mid-sagittal plane. These kids are definitely at risk of an abnormal neurodevelopmental outcome. High chromosome risk, high ventriculomegaly risk, high shunt risk, and poor childhood outcome in school. Megacisterna magna, though, have a good outcome. Blake's pouch cyst is pretty much a benign condition. And Vermean hypoplasia, while there's not a lot of evidence, in general, we feel that Vermean hypoplasia has a good prognosis. Any abnormality in the posterior fossa, please watch because they can go on and develop hydrocephalus ventriculomegaly. Please do antenatal testing on these babies on a weekly basis. It's important to make sure that these kids don't have a stillbirth in utero. Their delivery should occur at term. It's not going to cause harm having them. There's no need to have these babies preterm. They can deliver vaginally unless they develop massive ventriculomegaly. Again, that head circumference size of 40 centimeters and above predicts the need for cesarean section. Any child that has a brain abnormality detected on prenatal ultrasound, I would recommend that they be delivered in a big hospital. So they should be in a large city, high acuity, tertiary level facility. It allows the baby to have a fetal or a neonatal head ultrasound, a neonatal CT scan of the head, and neonatal MRI. When you make a Dandy Walker malformation, it's unlikely these recur, 1 to 5% recurrence rate. All the time, we would encourage these patients get a detailed anatomic ultrasound in a subsequent pregnancy. Key articles for you guys. So I've given you lots of homework assignments. This will be the last homework assignment in regards to the fetal head, but I had to go through lots and lots and lots of PubMed articles to find kind of the good ones. This article, Dandy Walker Malformation Complex, Correlation Between Ultrasound Diagnosis and Postpartum Neuropathology by Phillips. Really nice article and some good images to differentiate the different lesions. And then this one by Robinson, Diagnostic Imaging of Posterior Fossa Abnormalities in the Fetus in Seminars in Fetal and Neonatal Medicine. Also a really nice article if you want to hunt these down, that are available in your library and on PubMed on the internet. Okay, let's review a few cases. We use a lot of Philips ultrasound equipment in my office, and, I think you guys probably use some as well. This technology that is presented on our systems, we have ways to take beautiful 3D pictures. We have linear transducers that give us really nice imaging. We have tools like FlexView that allow us to show us coronal different planes if we apply lines in specific areas. We need to use the technology, and hopefully it's actually helpful to us in making diagnoses. So let's walk through a few cases here. And if you want to throw out some ideas in the chat box, great, or feel free to come off mute. These are some technologies that we use each and every day in my office. Smart Exam, protocolized exam, TrueView is that beautiful 3D imaging with the light that goes in and out of the volume, FlexView, the linear transducer, and then this new V92 3D mechanical transducer. All right, so here's a first case for you guys. 34-year-old, she's a G2P1. She comes to, your clinic for her first ultrasound. Crown rump length measures 10 weeks, 6 days, and, or supposed to be 10 weeks, 6 days, excuse me. Crown rump length measures 45.4 millimeters, 11 weeks, 3 days, confirms her menstrual dating. Heart rate 161 beats per minute. What do you guys think? Does this look like a normal pregnancy to you? I know it's just a couple pictures.
It looks normal.
Yeah, it looks pretty good, right? So you see a gestational sac, you see fluid-filled uterus, have a heart rate, and we've, confirmed her dating. We start scrolling through the baby, take a few pictures, and so we kind of transverse section of the head. I know, again, I'm just kind of teasing you with one picture. What do you think about that image? Transverse section of the head. Typically, I think you might see something different. What do you guys think about that?
Come on off mute, guys, or type in the chat box.
It looks like some anatomy is missing or fluid.
Yeah, the fluid in kind of the central portion of the head. I don't know, right off the bat, I don't see a midline falx. Right. Ideally, maybe
is definitely missing.
Definitely interesting. Okay, so we often start abdominally. Why don't we look a little more carefully vaginally? What do you guys think about that? I see 2 arms. Body looks okay.
Cystic hygroma.
Somebody thinks maybe a hygroma. Yeah, kind of at the back of the head does not look normal. I think we could say maybe that intracranial anatomy at the back's not perfect. Vaginal always puts the picture, the camera closer to the image, the anatomy we want. So I think anytime you suspect something, transabdominally in the first trimester, really encourage you to get your vaginal transducer out and look. So now maybe if up high, actually now I think I can see the cerebral hemispheres and the falx. So there's the 2 hemispheres, but it's a little bit lower kind of in the back. What do you guys think about that? Any diagnoses coming to mind? So if I show you these still pictures, Iswag said to make sure that the cranium was intact, right? And if we kind of zoom up here, this looks a little unusual, right? So like the skull, there's something like herniating out of the back of the skull here. So why ultrasound is so important, right? I mean, this patient came in thinking she has a normal pregnancy, and first picture you get transabdominally, you get a sense that head's not normal. And then
It says ventriculomegaly.
Yeah. What do you think this defect in the back of the skull is called?
Like an encephalocele?
Yeah, I love that term. So encephaloceles can happen really anywhere on the body, or anywhere in the head. It can be in the front, the side, the back, low down, high. This is called a fetal occipital encephalocele. This is the anatomic location of the cranial abnormalities. This is a defect in the skull. It's actually one of the worst forms of spina bifida. It's definitely in the spectrum of open neural tube defects. It's really rare, 1 in 13,000. And you see a calvarial defect and then an intracranial abnormality. The brain's getting kind of pulled backwards. We've lost kind of that cerebellar hemispheres and the vermis, etc. The prognosis in this is unfortunately not good. It's very difficult to fix the brain, push it back into the skull, and create a skull. And so this patient ultimately elected to not proceed with the remainder of the pregnancy based on our first trimester ultrasound. How about this one? 27 years old, G3P1011, comes in for her first trimester visit. She's supposed to be 11 weeks and 1 day. She is considered obese with a BMI of over 30. We use often this C51 transducer because it penetrates really well. As I told you before, I see a pregnancy. Yes, it's intrauterine. There's a crown rump, 45.8 millimeters, 11 weeks, 3 days. Do you guys, any concerns, thoughts initially?
The top of the skull.
Yeah, again, maybe it's related to habitus, but something looks a little odd right here. I would liberally encourage you to move from transabdominal to transvaginal anytime you have a suspicion about things. What do you think now? This doesn't look normal, right? We got the bottom of the baby,
but no top of the skull.
No top of the skull. Any diagnosis you would give to that description of anatomy? The brain's supposed to be in the skull, right?
Anencephaly, but the brain is.
It's like anencephaly. You're on the right path here. So let's just take a couple extra pictures. Here's a still one. Interestingly, many things in fetal diagnosis are a spectrum. Here you see the top of the skull kind of stops, and then the brain definitely, almost the entire intact brain is present in normal appearance, minus maybe a little deterioration of it in this fetus. And so we call this one fetal acrania, which is definitely part of anencephaly. It's usually the beginning part. So this is the worst form of an open neural tube defect. It's actually not that rare, but you have two neural pores that our body really is like a zipper, and the front of our body zips together and the back of our body zips together from 0 to 11 weeks. And the zipper did not fuse and close at the top of this baby's skull. And thus you have a lack of the cranium. ISWAG wants us to verify intact cranium. AIUM doesn't mention it. Importance of thinking about how we want to evaluate babies, how we want to do this in our institutions. Two first trimester examples of something that's very, very profound and has a big impact on the outcome of the pregnancy. This is a lethal abnormality. I like to use 3D technology a lot. This is a picture of that same fetus using the 3D 93V transvaginal 3D transducer. You can see the indentation where the skull ends and the brain is outside. The rest of the fetus looks normal. Turn a little bit. You can see the brain again outside of the skull. This is true view imaging. And then glass view, this picture, the patient actually really understood, was one of the ones that helped her. She could see the fetal face. She could see that the brain definitely was fully outside of the skull. She elected to not continue the pregnancy, understanding that this is a terminal lethal diagnosis. This is not her specimen, but this is an image from an article showing fetal acrania in the first trimester. Here's our ultrasound picture of the brain outside the skull. Here's a post-mortem autopsy image of a first trimester embryo fetal brain. The cranium did not fully close, allows the brain to escape the fetal head. Everything else looks anatomically and structurally normal. And because of our 2D imaging, our movement to transvaginal ultrasound, and our use of 3D to show the patient her actual fetus, her actual baby, she's able to actually make an informed decision about what she wants to do with that pregnancy. So please feel free to use and move to vaginal ultrasound and turn on the 3D, because it really does help the patient understand the diagnosis. Here's a later trimester case, 34 years old. She's a first-time pregnant patient, and we're looking through her baby at 26 weeks with the V92 transducer. What do you think about that one?
Cleft lip, possible.
Yeah, it looks like that nose is something's wrong there. These darn babies always have something in front of their face that makes these fun. This one has the cord, and maybe we're just trying to demonstrate cord. But yeah, there looks like right there's a little unilateral defect, right? C51 transducer, definitely you can see the unilateral defect. Higher frequency V92, there's a defect here as well. A little bit more crisp image, blacker blacks, whiter whites, a little greater contrast with the V92. We've started to use the V92 kind of as a primary transducer because it scans quite nicely. And then the cool thing is, when you have something like this, maybe you grab a quick 3D without having to switch transducers. So there's definitely a unilateral cleft lip. Let's look at that volume we can get. So here you see the baby, little alteration in the nose and that unilateral left cleft lip. There is a tool available now on our Epic and Affinity systems called FlexView. And FlexView is pretty cool. You can take this, you push your touch screen, there's just a little button that says FlexView. You can apply a line right directly across the fetal face. It gives you a slabbed kind of image. You can see that this is set at just a few millimeters here. And so there's a few millimeters of images slabbed together that gives us a perfect coronal image representing that cleft lip. But usually the patient's first question when you tell her there's a lip defect is there a palatal defect? And the palate's a little more difficult to look at. Yes, you can go up and down, you know, but wouldn't it be kind of cool? We could just draw a line right across where the palate's supposed to be. This line, actually, you can move up and down using the rotary ball. And again, you get that coronal image, and you just see that this is indeed just an isolated cleft lip. So using some 3D technology, using some measurement technology with FlexView, I can tell her confidently that there's no palatal involvement. This is simply what's represented here in figure A, a unilateral cleft lip with just alveolar involvement, not like C, where we see cleft palate involvement. So love using the V92, instantly able then to just grab a volume. If, say, you see a club foot or something, or you see a cleft lip or spina bifida, sometimes babies move. You know, you go to grab that transducer and switch to a 3D transducer. We might miss a couple opportunities to grab things. So we are primarily scanning frequently with the V92. And then FlexView is a kind of a cool tool, provides nice orthogonal plane review when you might need it. And for spina bifida is also FlexView. We try to use that with every spina bifida that we see. 3D imaging really helps the patient understand the diagnosis. Take pictures of their baby, show them their baby. I can show them cartoon pictures like I just showed you, but it helps the patient really understand what's going on with their baby. Here's the light on the outside, and here's the light right in that defect, giving that patient a really good understanding of what that baby's going to look like at birth. So there's not so much concern about the abnormality. They can grasp it and then come to grips to what the surgical repair is going to be. All right, one more case about the fetal head. 28 years old, gravida 1, para 0, 21 weeks, 3 days. You know, she's here for her initial ultrasound, and you put the transducer down and you see the image on the right. What do we think about picture 1? Normal? Not normal?
So definitely not normal.
Definitely not normal. Yes. Good answer. Yeah, I think you can see a significant amount of fluid in this fetal head, and some investigation is warranted. So we start looking through, you know, here's the transcerebellar plane, and midline falx. It does look like there's a cerebellum, vermis, cerebellar hemisphere, cisterna magna, nuchal fold measure normally. These portions of the brain pictures, where it's like, where's the choroid plexus? Where is the brain? So maybe very significant, you know, ventriculomegaly. What do you guys think of this? Just to kind of scroll through top to bottom. So we're going transventricular, transthalamic, transcerebellar. Not normal, right? I mean, I can't see the choroids. There's maybe a midline separating structure. I was thinking maybe like something like holoprosencephaly or something. The brain's a little disorganized. I'm kind of confused of the anatomy. The only thing that seems to be around is the posterior fossa. You guys have V92 transducers where you're working?
Yes.
Yes. Which picture do you like better, the C51 on the left or the V92 on the right?
Definitely V9 too.
Yeah, I mean, we use this every day because it penetrates, but this is really, I mean, it's just a really nice transducer. What do you see in this picture? Anything different that you see? There's an intact cranium, so you can see the skull all the way around here. You know, there is a midline separating structure, so probably not holoprosencephaly.
You don't see the choroid plexus or the ventricles or the thalamus. You don't really see, you see a lot of fluid.
Yeah. What do you think this is?
Is it a bleed?
Yeah. You know, if I go back to this picture, you can see this stuff. That's a medical term. And then you don't see anything in this C51. So we were kind of lucky evaluating this. Like this was on a day we were actually doing a V92 like research evaluation when this patient came in, and I was like, whoa, like I see some stuff in that dependent area. And as the baby's head moves, it seems to actually like move. So it's dependent debris in the skull, in the brain. So probably is like a bleed. Why would a baby have a bleed in utero? I wish I knew exactly, but this is a super unusual diagnosis. Does anybody have the actual term, the name for this? There's that dependent debris. Posterior fossa completely normal. Look at this beautiful cerebellum, vermis, cisterna magna, perfect interhemispheric fissure. There's that dependent debris. This is called fetal hydranencephaly, massive anomaly, really large fluid-filled cavities that replace the cerebral hemispheres. You can't see the choroid plexus or the ventricles at all. Commonly due to some type of infarct or anoxic brain injury. We don't understand why. And oddly enough, the cerebellum and the midbrain often are fully preserved, as like this case. We saw a perfect cerebellum and a perfect vermis. This is a very drastic abnormality. You can imagine what the outcome for a child would be if it has no cerebral hemispheres. This is going to be a profoundly abnormal, neurodevelopmentally delayed child. We take some 3D pictures to show the patient, again, that the skull, there is no brain tissue at all. We show that this is probably the remainder of some of the brain and probably a lot of blood from a massive injury to the fetal brain at 26 weeks. And then we use the light. You know, here's a coronal image. This is that transfrontal coronal image. We put the light actually into the volume, shadowing the opposite side because the interhemispheric fissure is definitely intact. You can actually see some of the thalamite preserved, but this is to demonstrate to her the baby's brain is severely damaged. And 3D technology, I mean, patients understand the 2D, but they tend to understand the 3D. And with the light, we're able to show them so much more specifics about the particular diagnosis. You know, we could send her to an MRI and that, but interestingly, that mid-sagittal Michelangelo view of the fetus, you know, shows the exact same thing as the $3,000 MRI. Facial profile is the same. Facial profile is the same. You can see the incredibly empty cerebral hemisphere here, and same on the MRI. This is not her baby; it's just a representative picture. But we can learn quite a bit using our ultrasound systems and just taking a few 3D pictures with that V92. Hydranencephaly is a really rare diagnosis. The V92 helped us make that diagnosis, and the 3D pictures helped us improve not only our physician, clinician diagnostic confidence, but also the confidence of the patient in the actual diagnosis. The patient elected to have an induction of labor shortly after this diagnosis with perinatal hospice, understanding the severe significance of this fetal finding.
Okay, that marks the end of our session today. And I really hope this was relevant for you and that it was a good spending of your time. And I would like to thank Dr. Ruma for sharing his insights and his perspective. And a big thanks to all of you for joining us today from all parts of APAC and beyond. The video of the webinar will be shared with you and it will be available soon. But before we end, we would love to hear your feedback on today's session to learn how we can further improve or provide you with even more relevant topics. So we have a couple of questions for you, and we would like to ask you, first of all, how you liked today's session. So how likely are you to recommend this webinar to a colleague, a friend, a peer, where 10 is very likely and 1 is not likely at all? And then we move on to the next question, which is, we're really curious to learn from you what topic you would like to see covered in one of the next webinars. So we're very keen to have your inputs here on topics for next sessions. So please use the text box here to provide your feedback. And then also make sure to hit the submit button. Thank you. Thanks for providing your inputs here. And finally, we have one more question for you, and that is just to have, if you have any other suggestion to improve our webinars or a comment you would like to share with us in general or on this webinar, then please type them in the text box. And I see we have 3 10s in the Q&A box. That's very good to hear. I'll give a little bit more time on this one. Great. Once again, thank you everyone for taking the time to join our webinar today, and enjoy the rest of your evening.
Không được kịp, ông phải tiêu vần. Trên lại. Mà ăn cờ đầy.
hả?
kiwi nó dễ sợ quá.
Nó dễ sợ quá, đúng rồi. Thôi mà đừng coi máu không vậy. Đỡ giờ vậy. Thôi ghê quá. Kéo cái ghế xích vô. Rồi lắc ra lắc cửa hơi té chứ mà chưa giờ.
Mở lại.
Đúng rồi đó.
Con có không? Ngày mai buổi thứ ba. Ngày mai thứ nhật.